This is Hypertension by Mary Caprio, Leah, and Shivani. Next slide. So we have the patient chief complaint symptoms and history of present illness. The patient chief complaint, Mr. Robert Johnson, a 56-year-old male, presents with his annual checkup with no specific chief complaint, stating he feels fine other than having frequent headaches. His symptoms obviously are frequent headaches, but he denies dizziness and or vision changes. His HPI, frequent headaches without dizziness and or vision changes. The case study does not present answers to typical Oldcart's mnemonic. He was diagnosed with prehypertension about 5 years ago and is non-compliant with home BP monitoring. His blood pressure in the office was 158/96. He lives a sedentary lifestyle and consumes a diet that is high in sodium. Medical history and surgical history. He was diagnosed with hyperlipidemia about 2 years ago, not currently on any medications, and he has mild osteoarthritis of the bilateral knees. There was no specific date in which he was diagnosed. Surgical history includes an appendectomy at age 12. Genetic factors and family history. His mother is living currently. She does have a history of hypertension, type 2 diabetes, and had a MI at age 65. Father is also living, currently has a history of hypertension and hyperlipidemia. Paternal uncle is living as well and had a CVA at age 67.
Patient's relevant risk factors. So, as mentioned before, lifestyle is sedentary with not regular exercise. A patient was also previously diagnosed with prehypertension with no follow-up for the last 5 years. His diet contains mainly high sodium, including frequent processed foods and canned soup. His weight is 220 pounds and is 6 feet. His BMI is 24.4. He falls within the overweight category. He denies any tobacco use, however, drinks a beer or two every evening. He has a mixture of both modifiable and non-modifiable risk factors. His current medications and allergies include multiple vitamins on most days and no known drug allergies at this time. In terms of cultural spiritual background, Mr. Johnson identifies as American. However, he does not report any cultural or spiritual practices.
Okay, so additional history I would ask. So I would want to know the onset and duration when he was first told that he had high blood pressure. Um, has he ever been treated with medications for this? And then monitoring, do you ever check your blood pressure at home or at the pharmacy? Additional symptom of uncontrolled hypertension, has he noticed any swelling in his legs? And then sleep history, any snoring, witnessed apneas, daytime fatigue. It's good to screen for sleep apnea because that is a secondary cause of hypertension. Stress slash psychosocial level of stress, coping mechanisms, work demands, support system, and then diet details, the specifics about sodium intake, caffeine intake, and daily water consumption. Um, And then alcohol use details. I want to know the exact quantity per week because he said a beer or two every evening. So I need a little more clarification on that. And then also I would ask about over-the-counter slash herbal meds, use of NSAIDs, decongestants, supplements, steroids, or energy drinks that may rise blood pressure, medication adherence slash access, whether cost, understanding, or side effects ever prevented his treatment. And then family history details. I want to know the age of onset for his family members of hypertension, strokes, and MIs. And then the additional review of systems I would ask for cardiovascular. Does he have intermittent chest pressure, claudication, orthopnea, paradoxal nocturnal dyspnea, because that could be early signs of heart failure. And then neurological, does he ever have transient weakness, numbness, speech difficulty, or visual changes? And that could be signs for a TIA or stroke. And then renal, foamy urine, hematuria, decreased urine output, to screen for kidney disease. And then endocrine, sweating episodes, palpitations, flushing, heat/cold intolerance, because that can screen for thyroid disease. And then peripheral vascular, any leg pain with walking or non-healing wounds, because that could screen for peripheral artery disease. Okay, and then probable focused physical exam findings. So vital signs, his blood pressure was elevated on repeat. It was 158/96 and it went to 156/94. That confirms that he had persistent hypertension. It wasn't just a one-time spike. And the two readings were on both arms to rule out measurement error and check for significant arm-to-arm differences, which could suggest coarctation or vascular disease. Heart rate was regular and normal. That can help rule out arrhythmias or tachycardia that might indicate secondary causes of hypertension. His BMI was 28.5, which is overweight. And that is a significant modifiable risk factor for hypertension. He was alert oriented and no acute distress. That indicates there's no hypertensive emergency, no confusion, altered mental status, or acute illness. Cardiovascular, S1 and S2 are present, regular rate and rhythm. Normal heart sounds, no gallops, which would be suggestive of left ventricular hypertrophy or heart failure. And then there was no murmurs, rubs, or gallops, which could be suggest a secondary causes like renal artery stenosis, a bruit that was radiating to the back. The peripheral pulses, 2+ and symmetric, that rules out peripheral vascular disease or aortic coarctation, which would have diminished pulses. And then no peripheral edema, which suggests no right-sided heart failure or advanced renal disease at this time. And then the focus, probable focus physical exam findings continued. Fundoscopic exam would likely be normal. In early hypertension, eye changes are often absent. Presence of hypertensive retinopathy, AV nicking, hemorrhages, or papilledema would suggest more severe or long-standing uncontrolled hypertension. There was no jugular venous distension, which means there's no right heart failure, no carotid bruits, which is less likely carotid atherosclerosis. There was no crackles or rales. There was no pulmonary edema, which would be seen in hypertensive heart failure. No renal artery roots, which can help rule out renal artery stenosis, which is a secondary cause of hypertension. There was no cyanosis, clubbing, or edema, which further supports that there is no end organ failure from hypertension. And then the neurological cranial nerves were intact and there was no focal defects, which rules out a stroke, TIA, or hypertensive encephalopathy. Normal neuro exam is expected in an uncomplicated hypertension. And then definition of hypertension. Hypertension is defined as persistently elevated blood pressure. Typically, systolic is greater than or equal to 130, and diastolic is greater than or equal to 80, confirmed on 2 or more occasions. So a normal blood pressure is less than 120 and less than 80. Elevated blood pressure is between 120 and 129 for systolic, and then diastolic less than 80. Stage 1 hypertension Systolic is 130 to 139, and then diastolic is between 80 and 89. Stage 2 hypertension is greater than or equal to 140 for the systolic, and then greater to or equal to 90 for the diastolic. So there's a few different types of hypertension. There's primary essential hypertension, which has no identifiable cause after a thorough clinical exam, which excludes all possible secondary causes. And that's about 90 to 95% of cases. Secondary hypertension results from an identifiable underlying condition such as kidney disease, endocrine disorders, or medication effects, and that's in about 5 to 10% of people. White coat hypertension is defined as having transient rise in blood pressure experienced by the patient when in a clinical setting or hospital setting, most likely due to anxiety, and that has a prevalence of 10%. And that's just when the blood pressure is elevated in a clinical setting, but normal at home. There's also masked hypertension, which is defined as hypertension that is present during daily life and absent in clinical setting. So there's the blood pressure is normal in the office, but elevated outside the clinical setting. Malignant hypertension is severe blood pressure elevation with acute target organ damage. For example, encephalopathy, stroke, MI. This is a hypertensive urgency/emergency, and this is in about 1% of patients that are diagnosed with primary hypertension. This is diagnosed when the blood pressure is 180 over 110 or higher, and evidence of acute target organ damage. And if it's not treated immediately with antihypertensive therapy in an acute care setting, then a hypertensive emergency can turn fatal. Then for global epidemiology, 1.28 billion adults ages 30 to 79 worldwide have hypertension, with 2/3 living in low and middle income countries. 46% of affected individuals are unaware of their condition. 42% are diagnosed and treated, but only 21% achieve adequate blood pressure control. Global prevalence is significantly higher in men, 1 in 4, than women, 1 in 5. Hypertension is a leading risk factor for cardiovascular disease, stroke, kidney failure, and premature death, responsible for greater than 10 million deaths annually worldwide. Although prevalence has shifted from high income to low income regions, overall rates remain high, highlighting the need for improved prevention and control efforts. And then for the US prevalence, 47.7% of US adults have hypertension. Hypertension is one of the most common chronic health problems seen in primary care setting, affecting nearly half of all American adults. Prevalence rises with age. So there's 23.4% ages 18 to 39, 52.5% in ages 40 to 59, and then 71.6% in ages 60 plus. Awareness of hypertension is in 59% of people, treatment is 51%, and control is 21%. And the prevalence is higher in men than women and highest among non-Hispanic Black adults. And then etiology for primary essential hypertension, it's multifactorial. The results from genetic, environmental, and lifestyle influences that increase vascular resistance over time. Like I said earlier, it accounts for 90 to 95% of all cases. There is no single identifiable cause. It is caused by a combination of genetic predisposition, and family history is strongly associated with that. Lifestyle factors like high sodium, obesity, physical inactivity, excessive alcohol, neurohormonal dysregulation, increased sympathetic nervous system activity, angiotensin, aldosterone system overactivation, vascular changes such as endothelial dysfunction, and increased arterial stiffness. And then secondary hypertension has identifiable causes such as chronic kidney disease, endocrine disorders, obstructive sleep apnea, certain medications like NSAIDs, oral contraceptives, and corticosteroids, alcohol, cocaine, and other substances. And then for risk factors, we have non-modifiable, which is age. The risk increases with age, family history slash genetics, race and ethnicity. There's a higher prevalence of hypertension in non-Hispanic Black adults, males until age 65, then females are slightly higher. And then modifiable risk factors is high sodium slash low potassium intake, obesity, sedentary lifestyle, excessive alcohol consumption, chronic stress, smoking slash tobacco use, and uncontrolled diabetes or dyslipidemia. And then for the pathophysiology of hypertension, the increased systemic vascular resistance causes structural changes in the arterioles, like remodeling and narrowing, and that increases arterial stiffness, raises resistance to blood flow. So the increased systemic vascular resistance and the arterial stiffness leads to increased afterload and sustained blood pressure elevation. Overactivation of the sympathetic nervous system increases the heart rate, vasoconstriction, sodium slash water retention, and the renin-angiotensin aldosterone system overactivity is when angiotensin 2 causes vasoconstriction. Aldosterone and then increases sodium and water retention, and that leads to increased intravascular volume and blood pressure. So the sympathetic nervous system and the renin-angiotensin aldosterone system overactivity causes increased vasoconstriction and increased volume. Endothelial dysfunction causes decreased nitric acid, which is a vasodilator, and then increased endothelin 1, which is a vasoconstrictor. Oxidative stress and inflammation contribute to sustained vasoconstriction. So endothelial dysfunction causes decreased vasodilation and increased oxidative stress. And then renal impairment, which causes sodium and water retention, volume overload. Kidneys fail to excrete sodium efficiently, which leads to fluid retention and plasma volume expansion. And then genetics and environment interaction increases risk and progression. The genetic risk factors affect salt handling, vascular tone, and the renin-angiotensin aldosterone system activity. And the environmental influences include high sodium intake, obesity, sedentary lifestyle, and stress.
You're mute, Mary.
The clinical manifestations that our patient was displaying was frequent headaches, which is a common symptom of hypertension. He was hypertensive upon examination. Oftentimes, hypertension can be asymptomatic, or it can present as headaches, dizziness, anxiety, fatigue, shortness of breath, and nosebleeds. Next slide. Review of pertinent positives and negatives. So the pertinent positives that our patient had, he admits to frequent headaches. He lives a sedentary lifestyle, consumes a diet that is high in sodium, often involving processed foods and canned soups. He does consume alcohol daily, drinking a beer or two every evening. He is considered overweight with a BMI of 28.5. Blood pressure, obviously he's hypertensive, 158 on 96. He does have a positive family history of hypertension, as both of the patient's mother and father have had hypertension, been diagnosed with it. Pertinent negatives, he does deny chest pain, numbness, and tingling in his extremities, weakness, dizziness, palpation, vision changes, anxiety, and or shortness of breath on exertion. Some differential diagnoses include migraine headache, cluster headache, tension headache, giant cell arteriitis, and a brain mass. Diagnostic criteria for hypertension. There's a couple different ways of diagnosing. There's three main methods: the office blood pressure measurement, ambulatory blood pressure monitoring, and self-measured blood pressure. So office blood pressure measurement occurs when office blood pressure measurements are above 130 systolic and 80 diastolic on at least two measurements during a single visit, or over 130 systolic or 80 diastolic on at least two separate visits during a 1 week span. Ambulatory blood pressure measurement method. ABPM is considered the gold standard for diagnosing hypertension, and it is truly a better predictor of future cardiovascular events when compared with OBPM methods. ABPM looks at the patient's average blood pressure within waking hours of a 24-hour span. It's looking at the average of about 14 measurements, and the hypertension is confirmed using the ABP method if the 24-hour average BP is greater than or equal to 125 systolic over 75 diastolic, and or the average daytime blood pressure is greater than or equal to 130 over 80. Sorry, there's a typo there. All right. Self-measured blood pressure method. The SMBP involves blood pressures being taken at home over 3 to 7 days. These measurements should be taken between 7 and 10 a.m. and another two readings between 1 and 10 p.m. These readings should be separated by a minute apiece. Hypertension is then diagnosed if the BP is greater than 130 systolic over 80 diastolic. Okay. This method is not used as frequently. It's considered outdated. This is a single encounter diagnostic criteria, and basically it's just a single measurement of a systolic greater than 180 and or a diastolic greater than 120. The other one is a single measurement of a systolic reading greater than 160 and a diastolic greater than 100 if there is evidence of a target organ injury. Staging of blood pressure. I know Leah went into this already. Normal blood pressure. I'm not even going to go through that because Leah's already gone through that once before. Next slide.
Okay, so this brings us into the treatment plan appropriate for adults. So first thing that we would want to look at is holistic lifestyle modifications. We'd want our patient to develop a healthy relationship with food. This means encouraging our patients to go to healthy community programs, where they will have education and support on foods to reduce calories, foods lower in saturated fats, and salts and processed foods, since majority of this patient's diets is high in salt, sodium, and is a lot of canned foods. Unfortunately, a lot of canned foods do contain a lot of sodium. We would encourage the patient to adopt the DASH diet, which would mean to consume foods rich in fruits, vegetables, and low-fat dairy products with reduced saturation and total fats. We also would encourage dietary sodium intake to be no more than 2.4 grams per day. Another major helper would be to increase physical activity. It may seem silly for a lot of patients when they think about modification that a 30-minute walk can't help, but it is proven again in academic journals that regular aerobic physical activity, at least 30 minutes of a brisk walk a day, can lower blood pressure. Weight reduction would help this patient with the blood pressure as well. We'd want to encourage him to maintain normal body weight as his BMI was 28.5 5. We would want it to be within the healthy category, which would be 18.5 to 24.5. Moderation of alcohol is also important. The limit of consumption to no more than 2 drinks per day for men and 1 drink per day for women. Stop smoking. Although our patient denied smoking, we just want to, we would just want to, I apologize. We would want to just encourage also no vaping. A lot of patients don't think that vaping is considered smoking. Um, Also, caution of the use of drug-induced hypertension, as Leah had said before, NSAIDs. There's some antidepressant, glucocorticoids, oral contraceptives, hormone replacement therapy, and over-the-counter decongestants that can increase your blood pressure. Mentioned also previously that there are certain stages of hypertension. The treatment plan would be based on the stage of the patient. So if we're seeing the elevated BP, we would encourage to adopt a healthy lifestyle and reevaluate the blood pressure in 3 to 6 months. In stage 1 of hypertension with low ASCVD, we would also continue to monitor lifestyle changes and reassess blood pressure in 3 to 6 months. In stage 1 with a high ASCVD, we would start lifestyle changes, but also implement antihypertensive medication, followed up by monthly appointments until the blood pressure is controlled. Within stage 2, we would continue lifestyle changes, antihypertensive medications from 2 classes, and continue monthly follow-ups until we have a stable blood pressure. Patients with diabetes and diagnosed hypertension would recommend strict blood pressure control, focusing on balances, med side effects with renal protection, and patients with chronic kidney disease and proteinuria, we would have more individualized goals as their treatment plan would continue with therapy individualized with closely monitoring renal function and medication side effects to aim and prevent neuropathy progression. After lifestyle modifications, we will continue to add medication into our plan of care for our patient. One of the first line of medications are diuretics to treat hypertension. So that would be our thiazide diuretics or loop diuretics or aldosterone receptor blockers. With these medications, you would want to watch out for hypokalemia, electrolyte imbalance. Next, we would follow up with beta blockers, and this is if indicated, not saying that we have to start right away. It would be based on the stages of hypertension for our patient. So each plan would be individualized based on the class that they fit. So then we would have the next class of medications, such as our beta blockers, which can cause bradycardia. So that's something that you want to let your patient know. Our ACE inhibitors, our ARBs, our calcium channel blockers. And for this, that we would want to take into consideration for our African American patients, that this is effective for them. We would also want to add our alpha androgenic receptor blockers, essentially acting agents. And then lastly, when in doubt, we have our combination therapies where we can combine more than one hypertensive. And this is usually not first line of treatment. This is towards the end stage of the hypertension in your more severe cases in your stage 2. Also with any comorbidities such as diabetes and chronic kidney disease, as mentioned before. In consideration of cultural and spiritual needs, we want to continue to take in consideration of our patient's needs. So I believe it was mentioned before in the case study, our patient doesn't have any cultural spiritual needs that prohibit him from following medication regimen. So we would want to just keep this in mind for any other patient. Some of them may want holistic approach to health, impact on healing and coping, ethical and professional standards, and cultural sensitivity and trust. In terms of diagnostic testing and genetic testing, as mentioned previously, family history can um, most likely indict 4 times as more for a patient with hypertension. Studies have shown that genetic contribution to essential hypertension is complex and has multiple genes involved. Genes that encode renin, androgen, aldosterone are currently being studied extensively, and African Americans demonstrate ethnicity relationships to hypertension and play a role on certain antihypertensives such as calcium channel blockers. Diagnostic testing and screening. So 18 years and younger, you are going to want to screen for high blood pressure at least every 3 to 5 years. Adults 40 and no less, you want to screen for sorry, there's a typo, blood pressure annually. Children and adolescents, it'd be very opportunistic unless they have any risk factors or comorbidities. Within our high risk groups, we would want to do annual, and our obese patients, we would want to continue screening often, African American as previously mentioned as well. Another screening tool is looking to see if our patient has metabolic syndrome. So this is a combination of arthrogenic and diabetogenic factors. Also another type, I apologize. Increased BMI, elevated systolic blood pressure, hypertriglyceridemia, hyperglycemia, and lower levels of HDLs are found in a person of this. So we're looking at waist circumference, triglycerides, HDL, cholesterol, blood pressure, and blood glucose for metabolic syndrome. Diagnostic testing, so these are some things that you would see. So upon physical examination, we would look to see if our patient is overweight, if they fit that criteria. As mentioned before, weight measurements, Leah did go into the fundoscopy that you would see some retinal changes, carotid arteries, neck veins such as distension. And some diagnostic tests contain UA, so you'd look for proteinuria. BUN and creatinine may be increased. CBC may show anemia. Potassium may be increased or decreased. Blood glucose most likely will be increased. Lipids will be increased. You would want to do a 12-lead ECG. This will target any. This will see to target any main organ damage, where you can see left arterial dysfunction, and BNP as well that you will see with an increase with myocardial demand. So some key points of patient education is to you would want to initiate aspirin therapy once blood pressure is controlled. Educate on oral contraceptives. Not many patients realize that that can increase blood pressure. You want to emphasize follow-up and compliance of appointments, medication adherence, and according to the KinCal pooled cohort risk assessment, if a patient is greater than 7.5%, it's recommended to add a lipid therapy. So also with this, it was mentioned that our patient was diagnosed with hypertension, pre-hypertension 5 years ago. So understanding the importance that it's a silent killer, blood pressure over 130/80, self-monitoring checks at home, follow-up care, lifestyle modifications, as mentioned before, medication adherence, as take prescribed medication and do not stop suddenly and report any side effects, and then warnings for severe malignant hypertension, such as severe headache, chest pain, shortness of breath, vision changes, weakness, and numbness. Recommendations for follow-up referral or community resources.
So we have initial management. We're going to begin with lifestyle modifications such as sodium restriction, the DASH diet, regular physical activity. weight loss if overweight/obese, and then limit alcohol and avoid tobacco. So then for the follow-up schedule, a follow-up visit should be scheduled every 3 to 6 months to determine effectiveness and adherence to the regimen of recommended behavioral changes. If lifestyle modifications were ineffective, pharmacological therapy should be started. After initiation of antihypertensive pharmacotherapy, a follow-up should be scheduled in 2 to 3 weeks for a blood pressure check and possibly in 1 to 2 weeks for an electrolyte or side effect check in at-risk patients. Once the blood pressure goal is reached, visits can be scheduled every 3 months, and more frequent visits may be needed if comorbid conditions exist. Serum potassium and creatinine should be monitored several times per year. For referral and escalation, patients with refractory hypertension, secondary hypertension, or comorbid conditions known to increase blood pressure should be referred to a cardiologist or hypertension specialist for further evaluation and management. Clinicians should refer patients with hypertensive emergencies to an emergency department or acute care setting for appropriate diagnostic testing, monitoring, and treatment. For community resources and patient support, there's local heart health programs, for example, American Heart Association, nutrition and exercise counseling programs, smoking cessation programs, and then patient education materials on home blood pressure monitoring and lifestyle change. So this is our genius questions.